We're getting much better to achieving remission. Our patient, as I say, 50 to 60% of patients at 6 months going to achieve remission. The problem we face now as clinician rheumatologists is to keep this patient into remission. So sustain remission, because what we observe in the CATCH database is that, yes, we achieve remission in 50% of the patient, but 50% of these patients do not stay into remission, so they're in sustained remission. They did achieve remission at some point, but they're losing remission. Most of these patients will switch from remission to low disease activity, about 2/3 of them. And 1/3 will change to high disease activity. And this is that worrying me about this study, why these patients achieve remission and losing remission over time to these patients. So there's still a care gap. The care gap now is that achieving remission is feasible, maintaining remission is much difficult. And what we observe is that it's more patients who are more prone to losing remission is more female, smoker, obese patient with higher comorbidity index at baseline, and seropositive patient. We also look at other factors. So there are other factors. So older age also was associated, longer time to achieve remission, first time into remission, or lack of early methotrexate treatment. So we delay treatment. Tapering also, it's a risk factor for losing remission. It's less clear because the confidence interval in these analyses were not conclusive. So we begin to understand why these patients and what are the risk factors of losing remission. Disease flare following patient achieving remission is very common in routine clinical care. We do not exactly understand why these patients have flares. Sometimes it's sustained flare, sometimes it's just one flare over time. So we need more study to understand why these patients are flaring, what are the risk factors for flaring, what is the consequences over time of these flare to improve our treatment approach.